good. Hi, everybody. I think we're about ready to get started. Hey, welcome. Welcome to the Health and Social Services Subcommittee hearing on the Behavioral Health Administration. Today is March 4th, and we have 10 witnesses signed up today, so thank you to those of you who are joining us for this budget hearing. We will begin, as we always do, with our amazing presentation by Department of Legislative Services. Welcome, thank you. Before I kick off officially, I just want to note that Chair Barnes of Appropriations, the full chair, will be here around 1:30-ish, so I will introduce him and thank him at that time, but just wanted to let people know that he'll be joining us today. All right, thank you.
Thank you, Madam Chair. My name is Naomi Camaro. I'll be presenting the fiscal 27 budget for the Behavioral Health Administration. So BHA in fiscal 27, the budget decreases by about 3.8% to $3.9 billion. Turning now to page 6 of the analysis, we've pulled out a couple of different measures from the Managing for Results data that BHA submits annually. The first is related to utilization among participants in the public behavioral health system. So between fiscals 2021 and 2024, utilization has been increasing across the different diagnosis categories, as seen in Exhibit 1 on page 7. The second measure is related to medication for the treatment of opioid use disorder, or MOUD. So BHA reports the proportion of people using PBHS services who use MOUD. And so from the exhibit on page 2, you can see that that proportion has been decreasing since fiscal 2021. I also wanted to point out that both of these data measures are missing for fiscal 2025 due to some ongoing data transfer issues with the new ASO, which I'll be discussing in a couple minutes. We've asked BHA to comment on whether or not these measures will be reported later, or if data for fiscal 25 will be absent from future submissions. Another data point highlighted in this section is the spending on MOUD in correctional facilities. The chart on page 3 shows that spending in fiscal 2023 by jurisdiction. So most of this funding is coming from the Behavioral Health Administration, and a provision in last year's BRFA authorized opioid restitution fund dollars for this use as well. On page 10 begins discussion of the fiscal 2025 budget. At fiscal 25 closeout, BHA canceled $6.1 million of reimbursable funds that were appropriated for school-based behavioral health services. This was because no providers submitted claims for this service. In fiscal 27, the allowance includes $9.2 million in reimbursable funds, which are available through the BHA Community Services Program. We've asked BHA to clarify the source of these funds in the Community Services Program and explain why they are budgeted here rather than in the Behavioral Health Medicaid program where they will be spent. And we've also asked MDH to discuss its efforts to enroll providers for the school-based behavioral health services. On the next page, we've summarized some of the funding in fiscal 2026, including legislative ads. The fiscal 26 budget included $3 million in legislative ads for the purpose of addressing pediatric hospital overstays, which the department has used to support the Brook Lane Hospital Overstay Program. There was also restricted funding in the fiscal 26 budget, again, of $3 million to address pediatric hospital overstays, which the department used to expand staffing at the John L. Gildner RICA facility. And so in fiscal 27, those funds are budgeted with the John L. Gildner RICA budget rather than in BHA. There was also $500,000 restricted in the fiscal 26 budget to procure drug detection products for students at colleges and universities. We've asked BHA to clarify on the amount of funding available in fiscal 27 for these restricted purposes. Next, I'll discuss the funding that's in the fiscal 27 budget. So as I said, the total budget in fiscal 27 for BHA is $3.9 billion. Majority of that is allocated to provider reimbursements. So the pie chart on page 13 shows that about $3.5 billion going to support provider reimbursement spending. Vast majority of that, 91%, is in the behavioral health Medicaid program. And then there's smaller amounts for services for non-Medicaid eligible services for Medicaid enrollees, as well as services for people without insurance. Excluding provider reimbursement payments, the budget total is about $421 million, and the purposes of those funds are summarized in the pie chart on page 14. So the largest share is going to grants to the local behavioral health authorities and core service agencies, which manage behavioral health programs and policies at the local level. There's also about $53 million for behavioral health investments. There's about $25.5 million for the 988 Trust Fund and Crisis Line. Pages 15 and 16 summarize the major changes in the fiscal 27 budget compared to fiscal 2026. So as I said earlier, the entire budget is decreasing by about $155.8 million. And about a net of $52 million of that is due to payments in fiscal 26 for prior year costs. So not including the deficiencies in fiscal 2026. That decrease is largely driven by lower spending in the Behavioral Health Medicaid Services Program of about $53.5 million compared to fiscal 2026. Next, I'll discuss the BRFA of 2026. There's 3 provisions in the BRFA as proposed that affect BHA. The first is a provision that would authorize the transfer of excess special funds from the State Board of Professional Counselors and Therapists to BHA. There's also a contingent reduction in the budget of $500,000 in general funds. And so if this transfer is authorized, that would replace the general funds with special funds. The second provision relates to CCBHCs. So under current law, the Department of Health is required to apply for the CCBHC demonstration grant in fiscal 27. This provision would authorize rather than require the department to apply for this grant, and it would also push the application date from fiscal 27 to fiscal 29. And then lastly, the final provision affects the assisted outpatient treatment program. So under current law, the department is required to establish an assisted outpatient treatment program, or AOT program, in any jurisdiction that is not opted to establish their own by the start of fiscal 2027. Because no jurisdictions have opted to start their own, MDH is going to implement the program statewide in 3 different phases, which I'll discuss a little bit more in a couple minutes. The provision in the BRFA establishes a cost-sharing model between the locals and the state, whereby in fiscal 2028, any jurisdiction in which MDH has established the program would need to pay back 25% of the program costs. In 2029, they would pay back 50% of the program costs, and so forth, until they are reimbursing the full cost of the program by fiscal 2031. However, we've also noted that the legislation that established the AOT programs does not require the program past fiscal 2030. So we've asked MDH to discuss why this cost share model was set up in this way so that payment would be due after the program terminates. The next section, next few pages, is a discussion of provider reimbursement payments for behavioral health services. So as I mentioned earlier, majority of the BHA budget is allocated to provider reimbursement payments through the Behavioral Health Medicaid program. Each year, DLS does a forecast to determine if the budget is adequate to meet the projected need for behavioral health services in the state. In fiscal 26 and fiscal 27, DLS is projecting pretty significant shortfalls for the Behavioral Health Medicaid program. The chart on page 18 compares the amount of money in the working appropriation in fiscal 26 to the amount projected. We're projecting about $125 million shortfall in the current fiscal year. And then in fiscal 27, we've compared our projection to the amount in the fiscal 27 allowance, where we're projecting about $175 million shortfall. So there's a couple of reasons that I want to point out that can help explain this, but I also want to caveat that due to some of the data quality issues that I noted earlier, there is a considerable amount of uncertainty with all of these estimates and projections, just based on the data that we have available. One pretty significant difference is in utilization. So DLS seems to be projecting higher utilization than what was assumed to develop the budget. We also have noted pretty significant growth in utilization over the past several years in some key service areas. So the chart on page 19 shows utilization, the average utilization rate across eligibility groups in 5 different services between fiscal 23 and 26. The 26 numbers include year-to-date actuals as of January 31st of this year, as well as what we're projecting for the entire year of 2026. Looking at these same services, we have compared what DLS is projecting for utilization and what was assumed for utilization in developing the budget as introduced. So that's Exhibit 9 on page 21, where we can see there's a decent gap in most service areas between what DLS is projecting for both fiscal 26 and fiscal 27 compared to what was used to develop the budget. We've also noted in the analysis that DBM was made aware of some ongoing reconciliation for certain services through December that will affect how much funding needs to be in fiscal 26 for fiscal 26 services, but they learned about this adjustment after the submission of the budget. Turning now to non-Medicaid provider reimbursement payments. Just looking at the chart on page 22, DLS is projecting very small surpluses in each of the non-Medicaid provider reimbursement payment programs, but again, the data is a bit shaky, and even more so for the non-Medicaid provider reimbursement programs. Unlike for behavioral health Medicaid, we don't have access to service level utilization data. This is something that we have asked for in the past that the department has not been able to provide, most recently because of sort of the data issues that have been happening due to the transfer, the ongoing data cleanup. I also want to note that in reviewing the budget data, we identified $45 million in fiscal 25 that was a negative $45 million, so it looks like a reduction in fiscal 25 labeled ASO provider forgiveness. We have asked MDH to clarify if this reduction is related to provider reimbursements and why the reduction was made. The next section is related to provider oversight. And so this describes how the authority of oversight over providers is split between the Behavioral Health Administration and the local behavioral health authorities and core service agencies. So while the CSAs and LBHAs do conduct site visits to providers and make assessments of their quality, they don't actually have the authority to compel the provider to take any corrective action. They have to report their findings to the department. We have asked BHA to comment on whether or not it has designated staff working with these local entities to investigate and then act upon any complaint findings. The second part of this part of the discussion is related to regulations around community-based behavioral health services. So legislation last year required MDH to submit some reports on their revisions to these regulations. Revisions to the regulations are ongoing, and we've asked MDH to provide an update on the status of the regulations. Pages 24 and 25 discuss personnel. In fiscal 27, there are 27.94 more contractual full-time equivalents in the BHA budget compared to fiscal 2026. 11.5 of these FTEs are for the AOT care coordination teams, which will start in fiscal 2027. We've asked MDH to discuss the other functions, or the functions supported by the remaining 16.44 other FTEs. I'll also briefly talk about the vacancy rate. So as of December 31st, BHA had a vacancy rate of 27.7%. They have indicated that since then they've filled 7 of the 60 vacant positions, bringing their vacancy rate to 24.5%. But we also have noticed that that still leaves a pretty big gap between the 12% needed to meet budgeted turnover in fiscal 2027 and 24.5% as of a few weeks ago. So we have recommended reducing funding to reflect a slightly higher vacancy rate of 15% in fiscal 2027. I'll now turn to the issues part of the analysis, starting with Certified Community Behavioral Health Clinics, or CCBHCs. So this part of the discussion just describes what CCBHCs are. They were introduced by SAMHSA, the Substance Use Mental Health Services Administration, to expand access to behavioral health care across the country. Exhibit 11 on page 27 shows the different funding pathways through which states can establish CCBHCs in their state. So SAMHSA awards planning grants to states to help them figure out how they can establish this model in their state. Maryland is currently under a planning grant right now and has been doing the work over the past year to fulfill the requirements of that grant. Then states can apply for a demonstration grant for 4 years to sort of pilot this model. And then states can choose after the demonstration to adopt a state plan amendment or a waiver to make this model a permanent part of their healthcare system. Clinics can also apply for funding through these expansion grants. There are 5 CCBHCs in Maryland, or 5 clinics that operate as CCBHCs in Maryland that receive this funding. However, because Maryland is not a demonstration grant, they're not able to bill using the prospective payment system. So rather than fee for service, they would be paid a daily or hourly rate, regardless of the amount of services they provide. And also under the demonstration, states are eligible for an enhanced federal match, which is not the case for clinics that are in states that have not yet started the demonstration. The next couple pages describe some of the requirements of CCBHC. So there's requirements around staffing, the types of services provided, the availability of services, as well as quality and data reporting. On page 29, there's a chart that just shows how other states have participated in the planning and demonstration grants. And then the next couple pages summarize CCBHCs in Maryland. So as I mentioned earlier, there is a provision in the BRFA that would authorize rather than require the department to apply for the CCBHC demonstration in fiscal 2027. And I've also noted that there are 5 CCBHCs in Maryland currently. 4 of them have grants with SAMHSA that are going to be expiring at the end of September of this year. And also, pardon me, I should have mentioned, there's $4.6 million in the budget, budgeted in the dedicated purpose account for MDH to establish CCBHCs in 2 clinics starting in January of 2027. So depending on the outcome of the BRFA provision, the department does plan to establish the CCBHC model at 2 sites beginning in January, and there's funding in the budget to do so. However, as I said, 4 of the 5 clinics have grants that are expiring at the end of September, and so that leaves a bit of a gap between September and January where they may not have complete funding for their operations. And so we've asked MDH to provide an update on its work with these clinics to determine a solution to provide the gap funding as needed. Exhibit 13 on page 31 summarizes the use of funding in the planning grant that Maryland has received, including funding that's already been spent and is planned to be spent to continue that work. On page 32, Exhibit 14 shows the cost to implement CCBHCs in some of the states that have participated in the demonstration. And the top line is for Maryland. This includes funding estimates from the Department of Health to implement the CCBHC model at 2 different clinics in the state. The rest of this discussion relates to outcomes based on data submitted by other states to HHS, as well as some independent valuations that that some states have procured on their own. It's a bit hard to generalize the outcomes across states because the geographies and populations are so different. Everyone's behavioral health care systems and structures are a bit different. However, we have noted that in terms of cost savings, it's been very hard to generalize and differs between states. Some states have said that they have seen cost savings related to reduced emergency department visits. On the whole, most states have seen pretty significant startup costs to establish CCBHCs, but across the board, every state has reported a significant increase in utilization of behavioral health services and an increase in expanded access to behavioral health services after implementing the CCBHC demonstration. I'll next turn to the issue starting on page 35, which is related to assistant outpatient treatment programs, or AOT programs. So AOT programs offer treatment for individuals with serious mental illnesses and who have been court-ordered to seek treatment. They're assigned a care coordination team who develop an outpatient treatment plan. And as I mentioned earlier, under current law, every jurisdiction is required to have an AOT program by July 1st, and any jurisdiction that has opted not to establish their own program, the department needs to establish one on their behalf. And so MDH is going to take a statewide approach to phase in the program across the whole state throughout fiscal 2027. We have asked MDH to explain why it has chosen a phased-in approach, given the requirement to implement the program by July 1st. Exhibit 15 shows the phases as introduced by MDH and their planned implementation dates, as well as the regions in which the program will be established. In fiscal 2026, there's $3 million in the budget to support the planning and setup of AOT programs in the state. MDH has indicated that of this appropriation, $2 million has been used to address program deficits, but we weren't clear how these deficits arose or in which programs those deficits exist. So we've asked MDH to clarify the deficits that it's projecting, in which program, and why funding for AOT is being used this way. In fiscal 2027, there's $6.7 million in the budget for AOT, and of that total, $4.2 million are for care coordination teams. Exhibit 16 shows funding from fiscal 27 through fiscal 29 for the care coordination teams in each of the 3 phases that I noted earlier. In addition, SAMHSA does award states funding to help establish AOT programs. And in fiscal 2026, MDH indicated that it was awarded 2 different grants from SAMHSA. We have asked MDH to comment on the amount of these grants and indicate if they are included in the fiscal 26 working appropriation, as well as indicate if they intend on applying for a forthcoming grant opportunity from SAMHSA. The next issue is related to the ASO. So as you know, as of January 1st, 2025, BHA has been using a new administrative services organization, Carelon, and they submitted some data in August of last year describing how that transition has been going. In general, Carelon seems to be processing claims in a timely manner. The chart on page 40 shows throughout calendar 2025 the number of claims processed each month, as well as the average number of days between the time the claims are submitted to the time the claims are adjudicated, so that by the time Carelon either approves or denies the payment. While it spiked in February, a month after the launch, it has largely been decreasing since then, reaching a low in December. I also have mentioned a couple times now the data transfer issues. So MDH has reported that there have been some challenges in transferring data between Optum and Carelon, and so there are ongoing data cleanup efforts. However, this has been complicating for data reporting, including for forecasting for the behavioral health services, as I noted earlier, especially for the non-Medicaid provider reimbursement data. So we've recommended restricting funding pending the submission of monthly non-Medicaid provider reimbursement data. We are also recommending adopting committee narrative, requesting another report on the ongoing transition to Carelon. The next issue is behavioral health investment spending. There is about $53 million in the budget in fiscal 27 for behavioral health investments. In fiscal 26, there was about $83 million in the budget. There is a proposed deficiency in this year's budget plan to withdraw $16.9 million of that in fiscal 26 to align with actual spending. The chart on page 42 shows the amount that has been budgeted for this purpose in each year between fiscal 2024 and 2027 compared to the actual amount of spending. So in fiscals 24 and 25, there was underspending due to program delays. Also in fiscal 2026, $3.5 million of the amount appropriated was used for the restricted purposes noted earlier, so to address pediatric hospital overstays and to procure drug detection products for students. We have asked MDH to clarify if fiscal 2027 appropriation will be used to continue funding for those purposes. We also have noted that in fiscal 27, about $17 million from this program is being used to support behavioral health Medicaid services for mobile crisis stabilization, and school-based behavioral health services, as well as the Medicaid reentry waiver. We've asked MDH to clarify the purpose of the remaining $36 million in behavioral health investments. The last issue of this analysis relates to the Behavioral Health Workforce Investment Fund. In October 2024, the Maryland Healthcare Commission released a report that said that to meet the current need, behavioral health need in the state will require over 18,000 more behavioral health workers, and made some recommendations around investments to recruit and retain behavioral health workers. Legislation in 2023 established the Behavioral Health Workforce Investment Fund, which has not had any funding added to it to date. And then also in September 2025, MDH indicated that it plans to establish a workforce development center to help address this workforce shortage. We've asked MDH to provide an updated timeline for the center and indicate if there are plans to invest any money in the fund in the future. The last couple things I'll note is there is an update in this analysis I'm not going to present that relates to the 988 Crisis Line and Trust Fund. And then lastly, I'll just go through the DLS recommendations. The first is the recommendation to reduce funding to reflect slightly higher anticipated vacancy rate in fiscal 27. There's 4 pieces of annual language that restrict funding between the 3 behavioral health programs and 1 provider reimbursement program in Medicaid. There is there's a recommendation to restrict funding pending the submission of the fiscal 28 budget, separating the provider reimbursements for the uninsured population from the rest of the community services program funding. There's a recommendation to restrict funding pending the submission of non-Medicaid provider reimbursement data. There's a recommendation to restrict funding pending the submission of a report on the timeliness of grant payments that was requested last year. I will note that since the writing of this document, the department has actually turned in that report. There's 2 recommendations related to adopting committee narrative, requesting a report on the ASO transition, and another one requesting a report on reimbursable funds spending and reporting in the Behavioral Health Medicaid Services Program. So that concludes my presentation, and I'd be happy to take any questions.
Thank you so much for your thorough, and thoughtful analysis. We really appreciate it. I see Delegate Reff has a question, but before we go to you, I just want to welcome our full committee chair, Ben Barnes, here for the Behavioral Health Administration budget. Did you want to say anything?
Thank you for having me, Madam Chair.
Thank you so much for being here. Delegate Reff.
Thank you, Madam Chair. Good to see you, Mr. Chair. And I'm going to stay on brand and ask questions about CCBHCs. So I'm looking at Exhibit 14 that you were discussing, talking about the 7 demonstration states. Federal government covers roughly 65% to 85% of total CCBHC costs in that exhibit, correct?
Yeah, I can't say for sure what percentage for each state, but
Okay.
they all have the enhanced match.
So, but the Maryland estimates say that the federal share would only be 39%. And if that's correct, why is Maryland's federal participation projected to be dramatically lower than every other state profiled?
So we asked the department this, and they said this is to make up for the funding needed to support services for the uninsured population, but I think it's a good question to ask the department. They'll be better equipped to answer it.
Okay. Were there any specific cost categories that were identified as ineligible for federal match in Maryland?
That's another question you'd have to ask the department because they have a better read on what services they'll be providing.
Okay, thank you.
Sounds like we have some questions for the department. Thank you so much. Really appreciate your analysis, Ms. Kimura. We will now call upon our MDH friends to join us. Secretary Seishamani and team, welcome. You may join us at the table, and when you are ready, you can begin. Welcome.
Good afternoon, Chair Barnes, Chair Shetty, and members of the Health and Social Services Subcommittee. For the record, I am Dr. Mina Seishamani, Secretary of Health for the state of Maryland. The department thanks the governor, the Department of Budget and Management, and the budget committees for their support. And we thank the Department of Legislative Services for its insightful budget analysis of the Behavioral Health Administration. I'm pleased to be joined here today by Acting Deputy Secretary Dr. Rachel Talley and Ms. Sonia Chesson, Senior Advisor to the Secretary, to discuss the fiscal year 2027 budget. Across the Department of Health, we are working to improve health across the lifespan, and behavioral health services is a cornerstone of this work. The governor's budget continues to make investments in Maryland's behavioral health services with $3.9 billion total funds budgeted in fiscal year 2027 for the Behavioral Health Administration and Behavioral Health Medicaid. Maryland's Public Behavioral Health Administration helps to ensure that more than 330,000 Marylanders receive mental health and substance use treatment services annually. I'd like to call attention to a few areas before turning it over to my colleagues to go into the specifics from the DLS analysis. First, CCBHCs, Certified Community Behavioral Health Clinics. CCBHCs are designed to ensure access to coordinated, comprehensive behavioral health care and are required to serve anyone who requests care for mental health or substance use, regardless of their ability to pay, place of residence, or age, focusing on crisis care, integrated physical and behavioral health, and coordination for vulnerable populations like veterans and youth. They operate a no wrong door approach to service provision. The department has received a no-cost extension from Substance Use and Mental Health Services Administration, or SAMHSA, to extend the CCBHC planning grant to December 30th, 2026. And we are appreciative of the governor's fiscal year 27 budget allowance of $4.6 million in a DPA to ensure that resources are available to support a future CCBHC demonstration grant application following the current planning grant period in the spring of 2028. Next, I'll turn to assisted outpatient treatment, or AOT. This is an intervention that provides court-ordered care to individuals with serious mental illness who have demonstrated difficulty engaging in treatment. The department has engaged in multiple efforts to implement a robust AOT program, including, but not limited to, stakeholder engagement through multiple advisory groups, the development of draft regulations, as well as program clinical and operational guidance, and the successful procurement of vendors for training and assessments. The fiscal year 2027 allowance includes $6.7 million for the administration and implementation of AOT programs across the state as we begin our phased-in approach, which the team will discuss further. And next, how we want to protect BHA investments. Last year, the Behavioral Health Administration released the first ever roadmap to strengthen Maryland's public behavioral health system for children, youth, and families. This was done in partnership with the Maryland Coalition for Families and Manat Health, and it addresses gaps in mental health and substance use services with specific recommendations on how to improve the system to better support our communities. Continued investments in BHA allow the department to continue meeting the 5 goals and 10 recommendations in that roadmap. The governor's budget also includes $54 million in funding for various investments in Maryland's behavioral health services, including 24-hour mobile crisis teams, initiatives to reduce hospital overstay for pediatric behavioral health patients, support for the bed registry and referral system established by House Bill 1121 of 2020, discharge initiatives at state and behavioral health hospitals, and to support crisis stabilization centers in Montgomery and Prince George's County. I would also like to highlight the administration's work to meet strategic plan goals by distributing over 400,000 doses of the overdose reversal drug naloxone through the Overdose Response Program. By partnering with community-based organizations and local health departments to distribute free naloxone and overdose education, this program has saved numerous lives across the state. So overall, thank you for providing me with an opportunity to highlight a few areas from the Behavioral Health Administration budget and the work that we continue to do every day to protect Marylanders. We look forward to continuing to work with you, members of the Maryland General Assembly, our advocates, and our communities as we together pursue our collective vision of a high-quality healthcare system that produces the best possible health for Marylanders across their lifespan. I will now turn it over to Dr. Talley to address the specific budget questions in the DLS analysis. Thank you.
Thank you, Secretary Seshmani, and Chair Shetty, Vice Chair Jones. Thank you for having us. The department thanks the governor, the Department of Budget and Management, and the Budget Committee for their support. And we also thank the Department of Legislative Services for its insightful budget analysis. And so now I will review our responses to the analysis. First, I will say in terms of the first action, reduce funding to reflect savings due to an anticipated turnover rate higher than budgeted in fiscal year 27. I'd like to address that a little bit later on because we do have a more detailed explanation there, and start with recommendation 2, if that's acceptable. So for recommendation 2, add language restricting the appropriation for LO 102 to only be expended in LO 102, LO 103, Q03 and Q10. The department concurs with this recommendation. We also concur with the recommendation for the similar restriction on LO 103, Q10, as well as Q10 and Q03. For recommendation number 5, the add language restricting funding pending corrective action from the Department of Health and a report confirming the status of each repeat audit finding. So the department does concur with that recommendation. Next, a language restricting funding pending the submission of the fiscal 28 budget, which includes a separate program for provider reimbursements for the uninsured and the underinsured. So the department does concur with that adjustment in terms of the fiscal 28 budget. We do respectfully request that the funding not be restricted. Next, in terms of adding language restricting funding pending the submission of non-Medicaid provider reimbursement data, the department concurs with that recommendation. Next, the recommendation to add language restricting funding pending the submission of a report on the timeliness of grant payments to local nonprofit core services agencies. The department supports this recommendation. We do respectfully request reconsideration of the deadline associated with the requirement. To better enable BHA to produce accurate reports, we respectfully request that the deadline be to the previous year's deadline of January 2027, as the proposed deadline does fall during a particularly busy period that will change our ability to produce accurate and timely reports. To the next recommendation, to adopt a committee narrative requesting a report on the administrative services organization transition. The department does concur with that recommendation. And additionally, the recommendation to adopt a committee narrative requesting a report on reimbursable fund spending and reporting in the behavioral health Medicaid program. So the department does support this recommendation. We do respectfully request that this reconsideration of the deadline associated with this recommendation to better enable BHA to produce accurate reports. We respectfully request that the deadline be extended by 1 month to August 31st, 2026, as the proposed deadlines falls during a particularly busy period that will change our ability to produce accurate and timely reports. And then lastly, the adding language restricting the fiscal 26 deficiency appropriation for Q10 to be expended only in the LO102, LO103, Q03, and Q10 programs. The department concurs with that recommendation. And next, moving to some of the questions proposed by DLS within the analysis. So first, the request that BHA should comment on whether the medication for treatment of opioid use disorder measures within the Managing for Results analysis will be reported at a later time in fiscal year 26, or if the data for fiscal year 25 will be absent for future MFR submissions. So all data from the ASO transition period will be available after mapping and vetting processes are complete. MDH will work with DBM to update the fiscal year 27 MFR to reflect the vetted data, and future MFR submissions will include that data. And MDH is working closely with Carillon to fully vet and create data reports with recent data, and expects that the data reports will be ready for the MDH analysis by the end of March. At this time, we can share that the MOUD percentage for the first half of fiscal year 25, based on claims paid to December 31st, 2024, is 26.4%. And this represents only those MOUD services rendered and paid for before the January 1st, 2025 Carillon BASO transition. And so this is an outcome measure that is updated monthly, and as data related to these finalized claims are captured from prior payments, this indicator will be updated. Next, the question that BHA should clarify the source of available funds for school-based behavioral health services in the Community Services Program, and why these funds are budgeted in this way instead of directly in the Medicaid program, and also that MDH should discuss its efforts to enroll providers for these services. So the school-based behavioral health services are budgeted in the sub-program for BHA behavioral health investments. This is because as the service ramps up, MDH is seeking budget flexibility to support behavioral health investments, some of which also have variable spending during implementation periods. And once school-based behavioral services reach a steady state, we will explore realignment of the general fund budget from BHA to behavioral health Medicaid. In terms of efforts to enroll providers in these services, so beginning January 1st, 2025, as part of our efforts to expand access to behavioral health services in schools, local education agencies have been eligible to receive reimbursement for certain school-based services for behavioral health provided by Medicaid and provided for Medicaid enrolled students. And specifically, these are certain services delivered by school psychologists and social workers, and these can be billed by the LEAs to the Maryland Department of Health Medical Assistance Program. And so as part of a 3-year, $2.5 million CMS grant, MDH has added 3 staff members to support the expansion of this service and enrollment. And this includes both a program manager and a health policy analyst, as well as a dedicated resource to the provider enrollment staff to support enrolling these providers. And so these providers did begin enrolling January 1st, 2025 under a new provider type, and there are 582 providers that are enrolled to date. MDH did also issue a joint transmittal from the Secretary of Health and the Superintendent of the Maryland State Department of Education to announce the rollout of the program and to encourage providers to enroll as well. We've also conducted training webinars and in-person seminars in 5 regions to cover all LEAs throughout the state to encourage enrollment in this program. And we have had major support from the head of MSD's school psychologist program as well. Next, the question that BHA should comment on how much funding is available in fiscal year 27 to support the Brook Lane Hospital Overstay Stabilization Program. So the fiscal year 27 budget does include $3.5 million for Brook Lane Hospital overstay, supported by the MS40 Behavioral Health Investment Fund. Next, BHA should clarify if there is ongoing funding for drug detection products included in the fiscal year 27 budget. So the State Opioid Response, or SOAR 4 federal award, which is budgeted in fiscal year 27, does support the purchase of drug detection products, and this is budgeted in subprogram MS47 in the amount of $167,279. Next, MDH should clarify if any other funding in the fiscal year 27 budget supports the Baltimore City Capitation Project. So the fiscal year 27 budget for Baltimore City Capitation allocates $4.8 million in general funds and $3.9 million in federal matching funds for the Baltimore City Capitation. These items were assigned to the CSA contracts in the budget system detail, and so we will work with DBM to update the contract name to reflect Baltimore City Capitation. Next, MDH should discuss why a cost share is established for a year after the AOT program terminates in statute. So the BRFA language specifies cost sharing based on the state's share of associated costs for the AOT program. And so if an AOT program was no longer operational as of 2031, there would be no state costs to share in that year. Next, MDH should clarify if the $45 million reduction in fiscal year 25 is related to provider reimbursements and why the reduction was made. So yes, this is related to provider reimbursements. This item was mislabeled in our actuals, and it does not tie back to ASO provider forgiveness, as was specified in the analysis, but rather to services reimbursed through the ASO. And so these were expenditures that were moved to the the services that were eligible for the medical assistance federal match that were realigned to program Q10 for the purpose of supporting provider reimbursement from our community services fund. Next, BHA should comment on whether or not it has designated staff working with LBHAs and CSAs to investigate complaint findings and take appropriate action. So yes, the Behavioral Health Administration employs a dedicated complaint coordinator and a critical incidents manager to oversee the review, triage, and dissemination of reports to the appropriate local designated authorities for investigation. And following the completion of investigation, the local authority reports their findings back to the designated BHA staff. If the results indicate that disciplinary action is necessary, the report is submitted to the Director of Licensing and Compliance, and the Director then consults with the Assistant Attorney General assigned to BHA to determine the appropriate sanction and address provider appeal rights. Next, MDH should comment on the status of the regulations for community behavioral health services, the COMAR 1063 regulations. So the department is revising the COMAR 1063 regulations, which detail the licensure, staffing, reporting, and other compliance requirements for community-based behavioral health services. The department has released 2 drafts of updated regulations for informal comments, the first in December 2025, and then the second with updates based on stakeholder feedback in mid-January 2026. Both versions are available on the BHA website, and MDH is holding additional informal stakeholder meetings before releasing draft regulations for formal comment. Next question was for MDH to discuss the functions supported by the remaining 16.44 new contractual FTEs. So in our response, we have included a table specifying the function of each of these FTEs. Rather than reading out line by line, I'll generally share that these support various sort of programmatic components within the BHA system: clinical consultation to the chief medical officer, clinical supports in our treatment recovery program, including MDRN, support in terms of data needs in our behavioral health research and innovation division. So a variety of programmatic and analysis functions across the Behavioral Health Administration. Next, and this is going back to that first recommendation listed in the report, that DLS recommends reducing by $725,000 to reflect a higher amount of savings from a higher than expected turnover rate of the 15%. So the department does respectfully disagree with the DLS recommendation to reduce BHA's current year general fund budget to account for perceived merit vacancy savings. We'd like to first provide some background on the vacancy rate before directly addressing the proposed reduction. BHA had 46 new merit positions authorized in fiscal year 25, and so receiving so many new PENs at once did drive BHA's vacancy rate up by nearly 20% to 39.7% in December 2025. BHA's vacancy rate has fallen steadily since then as positions have filled to 26.9% as of February 28th, 2026, or 55 vacant positions. We would like to note that the General Assembly has already reduced BHA's current year general fund payroll budgets by $1.1 million through Section 38 and Section 41 in fiscal year 26 budget bill. This reduction carried forward into BHA's baseline general fund target for fiscal year 27. And so in this way, the General Assembly has already reduced our fiscal year 27 budgets in BHA and throughout the department to account for perceived vacancy savings. And second, we would note that BHA's vacancy rate rising above budgeted turnover does not necessarily translate into further budget savings. A majority of the vacant merit positions, 36, are in BHA program direction, which is a program which has a projected payroll deficit in the current year, in large part due to the Section 38 and Section 41 budget reductions. And so the reduced funds are needed to support hiring new employees to step above budgeted levels. So this proposed reduction would drive the BHA program direction budget further into deficit by taking away budget resources tied to vacant positions that are underwriting the cost of filled merit positions whose collective payroll costs are above the budgeted level. The additional annual salary costs for merit positions filled above the budget level is $865,760, and on average, these positions are filled at 4.7 steps above the budgeted step. And as the DLS analysis indicates, 35 of BHA's vacant positions are currently in various stages of recruitment. And so the proposed DLS reduction would severely limit MDH's ability to proceed with active recruitments and any further hiring efforts. And filling these vacancies is crucial not only for maintaining our current service levels, but also for strengthening our overall operations and programs. Several of these positions are related to the federal block grant management, licensing and compliance, local planning, and additional positions are needed to fully staff the fiscal and grant management team, which ensures timely awards and provider payments, et cetera. And so a full complement of staff does enhance our capacity to deliver essential services. Next, MDH should provide an update on its work with clinics to determine a solution to provide bridge funding to CCBHCs if necessary. So we do want to note that the services by current CCBHC entities are individually billable in our current system, services such as outpatient therapy, psychiatric rehabilitation, services for children and youth, crisis service, et cetera. And that SAMHSA has also confirmed that the expansion grantees can reapply for expansion grantee funding or apply for no-cost extension for unexpended grant funds. However, MDH is exploring the request for bridge funding from the current CCBHC sites should expansion federal funds not be awarded. Next, MDH should discuss why it has chosen a phased-in implementation for assisted outpatient treatment, given the statutory requirement to implement in all jurisdictions on or before July 1st, 2026. So the decision to adopt a phased-in approach to AOT was in response to robust feedback from local jurisdictional leadership recommending a phased-in approach with initial pilot regions as the optimal pathway for program success, given the complex cross-sector nature of the AOT program. The department is firmly committed to the plan to ultimately roll out the AOT program statewide by the end of fiscal year 27. Next, MDH should clarify the deficits that it is projecting in each program and why funds for the AOT program are being used in this way. So in recent months, the department has seen a large increase in ASO reimbursement costs, as was noted in the analysis, across BHA community services, BHA state-funded Medicaid, and behavioral health Medicaid. And so these expenditure increases are driving up projected costs for the current year above the budgeted levels, inclusive of the budget bill deficiencies. Some of the services currently projecting the largest deficits are SUD residential, SUD ambulatory, psych rehab, inpatient, as well as community-based outpatient services. And so some of the current year budgeted funds tied to the AOT program are available to offset the projected expenditures due to the timing of the phased-in approach for AOT. The fiscal year 26 budget for AOT will be used to support program implementation costs for one region rather than 3. And the department also notes as well the connection between AOT and ASO reimbursed services, namely that it is the expectation that a significant proportion of AOT treatment plan services will be provided through the public behavioral health system. And so this realignment of current AOT funding will help to provide adequate budget support for ASO services that we'd expect to be provided to AOT patients. The department is working with DBM to realign projected budget surplus from Medicaid programs to support behavioral health budgets. Next question is that MDH should specify how the care coordination team services will be divided across the AOT regions noted. So MDH has developed projected staffing models for year 1 of each proposed AOT region based on our projected year 1 AOT capacity. Importantly, the year-over-year volume in each region is challenging to predict given the new pilot nature of the program and difficulty with comparison to other states due to differences in our statutory staffing requirements for AOT. However, we do know that we are currently projecting to include 1 FTE AOT program director, between 0.4 to 0.8 FTA at 0.4 to 0.8 FTA psychiatrists, 2 to 3 case managers, and 2 to 3 certified peer recovery specialists in each regional program. Next question is for MDH to comment on the total amount of the fiscal 26 awards for AOT from SAMHSA, and if they're included in the fiscal 26 working appropriation. In addition, whether MDH intends to apply for the forthcoming SAMHSA grant opportunity. So MDH was awarded 2 SAMHSA supplemental funding opportunities in fiscal year 26 for AOT. This included a 1-year supplemental award through the Community Mental Health Services Block Grant for $416,515 and an increase in the department's existing SAMHSA PATH award in the amount of $11,303. And MDH is closely monitoring the AOT SAMHSA grant forecast and does intend to apply if that opportunity is opened. And these 2 awards were included in the fiscal year 26 working appropriation. Next, DLS did recommend restricting $500,000 in general funds pending the submission of monthly non-Medicaid provider reimbursement data. MDH does concur with that recommendation. Next, to continue monitoring the progress of the ASO transition, DLS recommended adopting committee narrative, requesting a report, updating the budget committees on the transition, and identifying any challenges or issues that may develop, and MDH does concur with that recommendation as well. Next, MDH should clarify the purpose of the remaining $36 million of investment funding in fiscal year 27, and in addition, MDH should indicate the fiscal 27 budget will continue to fund the purposes for which funding was restricted in 26. So we'll note that there is an Appendix A, which shows the behavioral health investment spend plan for fiscal year 27. The fiscal year 26 budget restricted $3 million of the BH spend plan for pediatric overstays, and the fiscal year 27 spend plan does include $3.5 million to address pediatric overstays through the contract with Brook Lane. Lastly, MDH should provide an updated timeline for the Center for Excellence for Children, Youth, and Families, and indicate if there are plans to invest any money in the Workforce Investment Fund in the future. So in terms of the center, development of a comprehensive financing plan to maximize the efficient use of federal and state funds has not yet begun. However, initial steps have been taken to map existing Medicaid funding streams, including those supporting the expansion of the 1915I services and EPSDT services under CHIP. And so a revised financial plan is not fully developed. Current efforts are focused on optimizing existing funding sources. And so with that, happy to take your questions. Thank you.
Thank you so much to the MDH team. Really appreciate you being here before us today. We will start with subcommittee member questions. Do I see Delegate Ruff ready? Okay, great, thank you.
Thank you all so much, Madam Secretary, Dr. Talley, and Ms. Chesson. All right, thank you so much for your presentation. It's very thorough. You guys obviously worked very hard on that. I wanted to go back to my question to Ms. Kimura about CCBHCs and the difference between the federal cost savings that is displayed in that exhibit. So I'll rephrase it. The federal government in that exhibit shows to roughly cover about 65 to 85% of the total CCBHC costs in the 7 other states. The Maryland estimate is significantly lower at about 39%. Is Maryland's federal participation projected to be dramatically lower than every other state profiled, and why?
So happy to take that, and thank you for the question, Delegate Ruff. So as Naomi began to allude to, one element of this is that we do have services in our system for individuals who are uninsured, who are not Medicaid eligible, and therefore cannot draw down that federal Medicaid match. And so that is part of that different calculation where we would then, there's a different proportion in terms of where our state funds would provide coverage.
Are there other cost categories besides the uninsured category where, those costs would be ineligible for federal match?
Right. So we do have other services within our system that are state-funded services. I would say I would have to take back as far as perhaps a specific detailed list within our CCBHC category of which services there are, but we do have some clinical services that are state-funded only, not Medicaid eligible, that also do not draw down a federal match.
Okay. Staying on this topic, we looked at the New York piece. It said that CCBHC implementation was associated with a 61% reduction in inpatient utilization and a 54% reduction in all-cause readmissions, and it produced a net budget savings. Maryland CCBHC grantees report similar reductions from the 5 that we have here. Has the department independently validated those claims? And has, I believe you all responded to our budget language from last year. Have you all been able to compile the cost savings so that we can consider pursuing those in future fiscal years?
So appreciate the question. And I'll say first in terms of the claims from our current CCBHC partners who we welcome collaboration with as far as our planning grant. So we have not independently validated those reports, but are very appreciative of the incredible contributions those CCBHCs have made to our communities. And I will note that we have the forthcoming JCR that is a cost-benefit analysis of CCBHC as well.
And so that's the response to the budget language we put together?
Yeah.
Okay, so no previews?
No previews, I'm sorry. Only in respect for our staff, I don't want to get over my skis in previewing anything, that would be inaccurate.
Okay.
I just want to interject here and remind everyone that she's been on the job for a week. And so welcome.
Thank
and
you,
we're
Chair
very
Shen.
grateful for how well you're doing.
Thank you, I appreciate it.
Yeah.
I'll pass the mic at this point, but thank you very much. Thank you. Thank you.
Didn't mean to cut you off. I'm sorry, Delegate. Come back, please. I really do apologize. I'm sorry. Delegate McCaskill.
Thank you, Madam Chair. Welcome. Congratulations to you. So we'll be gentle. Good to see you as well. I am going to refer to page 7, looking at the behavioral health system utilization chart. Perfect. So I noticed that the data, there is a decline, a steady decline amongst the years. For people using the public behavioral health system from 2019 into 2024, and that colorful, beautiful, colorful chart. So I see that there's a decline. Can you explain to us what can be causing the drop in utilization of the system from 2020 to 2024?
2020 to 2024. Well, thank you for the question.
Sure.
And I will say that, one, I think that our analysis, the utilization data that we're looking forward to from Carolyn, I think will shed some light in terms of our current system and utilization. I would note that some of the variability across years can, if we're looking earlier in 2019 to 2020, of course, can relate to the pandemic in terms of differences in terms of utilization. I will note that there are areas, I think, looking to the same chart, making sure that we're both referencing Exhibit 1 is what we're looking toward, that chart.
Correct.
That we do see some areas where we see an increase in terms of total individuals treated in terms of the overall trend, and individuals with a mental health diagnosis treated as well.
Okay, perfect. A follow-up question. What outreach efforts does your agency use to focus to access the system in detention centers?
Detention centers. Well, first, thank you for the question, and I'll comment that our investment in MOUD and detention is an area that we are particularly proud of in terms of the ways in which we've put forth our SOAR dollars in support of that work. In terms of outreach, we closely collaborate with our partnering folks in the justice system on the ground in terms of that funding to, consistent with that mandate to support that care.
Okay, perfect. I think that's it. Thank you so much. Thank you, Madam Chair.
Well, you're welcome. Did you want us to come back to you, Delegate Ruff?
I had a question about the general fund deficits. So yeah, and my mic is already on. Going back to page 18 on the analysis, there's an anticipation of a deficit of 125 million in last fiscal year, and up to 175 million in general funds in this fiscal year coming. For for behavioral health Medicaid program. Given that the average utilization rate for services like community-based services and applied behavior analysis therapy has significantly increased over the years, how does BHA plan to reconcile the gap in funding, the enrollment uncertainty due to HR 1 and the trend of utilization increases for behavioral health Medicaid services?
Well, thank you for the question, and appreciate you highlighting that. I think HR 1, of course, casts uncertainty in terms of where our Medicaid enrollment will go and how that will impact utilization. We do believe that as our data systems are validated through Carillon, that will help us to shed some better light in terms of prediction with some of these deficits. Candidly, there is some degree to which it can't fully be predicted in terms of utilization over time, that there's variability in terms of patient use of the system and where those trends will go. But I think we would be planning to most rely on our analysis of our Carillon provided utilization patterns to improve our prediction ability in terms of utilization.
Well, I guess my question is this a temporary imbalance, or is it more of a structural deficit in this program?
Just in the behavioral health program.
In the Medicaid, in the behavioral health Medicaid program.
Right. I think that I might ask to take that question back, maybe to do a bit more digging with our Medicaid team in terms of how best to frame a response to that question. But thank you for the question.
Okay. All right. Thank you.
Thank you, Delegate. Delegate Heimbach.
Thank you, Madam Chair. And as my colleague said, thank you for that thorough response. Seems like you're off to a really good start to me. You've hit the ground running, so.
That's very kind,
I'm sure
thank
your
you.
sure your boss appreciates that. My question has to do, on page 5 of the analysis, on the 998 crisis line and the fund. And in 25, the revenue from that was about $15.2 million, which was, I think, a little less than anticipated, but it looks like in 27, you're almost doubling the revenue to $29 million. I'm just curious, what's that based on? Why do you project the doubling of the revenue?
Sure, thank you for the question. And I'll note, just making sure that we're looking to the same piece, that our estimated revenue, we do have that 21.7 million to 21.9 million. And I think that that is a question that I would look to take back to our colleagues in the Department of Budget Management in terms of sort of the technical specifics of those projections. But thank you for the question.
Thank you. Thank you, Madam Chair.
Thank you, Delegate. Delegate Stanko.
Actually, I'm good. Thank you.
All your questions have been answered? Okay. Madam Vice Chair.
Thank you so much, Chair, and welcome. Welcome.
Thank you.
So let's flip over to page 16, please. I will do the same. Page 16, let's take a look at the analysis to discuss the pediatric hospital overstays. There's an other bucket, if you will. There is $3 million allocated to fund additional staff to address hospital overstays. It's my understanding that this was a reclassification of prior PINs to be used for this purpose. I get it. There were some shifting of funds from BHA to MDH administration, but there still seems to be $3 million unaccounted for. Are those considered one-time funds? Can you help explain that to me?
Sure, and thank you for the question, Vice Chair, and I think I'll turn this over to my colleague, Ms. Chesson, to address this.
Sure, thank you so much for the question, Vice Chair. So the $3 million is being used to pay for the PINs that are now being hired for that RICA.
Okay. Go ahead.
Yeah, sorry. So there are 3 million, there's a new 5-bed unit, and the 3 million is being allocated for that purpose.
And how far along are you in that process of hiring?
We're currently in the process of hiring right now.
So it's been advertised, you're interviewing, we're well off into the.
Yes.
Okay.
Yes, sir.
Thank you. Page 3. Page 3 mentions that BHA cited program implementation delays as a reason for underspending appropriated funds. So when it comes to supporting important initiatives like addressing hospital overstays, help me understand, what was the reason for the delays? Have you implemented changes to avoid those types of delays in the future?
Absolutely. I can speak to that, and thank you for the question. So first I'll say that we are committed to utilizing our behavioral health investments in the best way to to support existing initiatives, to bring new services online. Some of the delays that are spoken to, I think, are particularly some of our behavioral health investment fund provides support to some of our newer services, particularly services within the crisis continuum, services related to youth. And so there can be delays in terms of operationalizing a new complex program in the system where providers may first be getting into the flow of that operational setup, how to align best with our regulations, how to align best with our program guidance. And so I would say those delays, much of it relates to the newness of some of the services coming online supported through that investment fund. That being said, I'd say we're very committed to lessons learned from those sorts of delays and those sorts of operational hiccups and supporting those that we're investing in as best we can to bring those newer services online and fully expend these funds.
Okay. Thank you so much, Chair.
Thank you, Madam Vice Chair. I want to just tag on a little follow-up on the discussion you just had with Madam Vice Chair. So I thought, if I recall, that the $3 million reclassified PINs for FY26 was intended to cover the full fiscal year. And now that you are bringing those individuals on now and we're, a little more than halfway through the fiscal year, are you expecting there to be remaining dollars in that $3 million that's unexpended?
So I might defer that to Ms. Chesson as well, if that's okay.
I was kind of looking in the
Yeah,
general.
yeah.
Thank you for the question, Madam Chair. I think I'd probably have to go back to our budget people to see exactly where we're going to be in terms of hiring. We want to make sure that that unit is staffed up as soon as possible. So.
Yes, absolutely. Agreed. We want to make sure that's the case. And I'm just curious then, if you end up not utilizing the full $3 million because it was intended to cover for the full fiscal year, will you do a planned reversion, or will you reuse those dollars for something else that's needed immediately in FY26 that's part of the pediatric hospital overstay effort?
I think, Madam Chair, I'll have to take that question back to understand how those funds will
Great.
be used exactly.
Let's keep chatting then. Appreciate it. Okay, I want to talk a little bit about AOT. So, we know that in the 2026 BRFA, you've included a provision that requires local jurisdictions to reimburse MDH for progressively greater shares of costs from FY28 through 31. So we're already hearing from delegates and senators from across the state, and they're hearing from their constituents about this cost shift to the locals. So I just want to talk about that for a bit. So in page 39 of the DLS analysis, it notes that it's unclear which local entities will actually be responsible for reimbursement. And I want to add on to that, not only which ones, but also what amount, right? Because the program, I think wisely, truthfully, is being rolled out as a pilot project that's regional, and you have phases, right? You're being very thoughtful about your approach and how to roll this out. Can you share with us more details on how you're going to determine which local entities will be responsible for reimbursement under the BRFA provision, as well as, what amount each of them will be responsible for?
Yeah, I'll take that. Chair Shetty, thank you for the question. So the BRFA language at this time does not specify whether, the local government or LBHA would be responsible. And I think in terms of the amount of money, as you alluded to, we absolutely want to work in partnership with our regions as we roll this out to make sure that we are rolling this program out in the most effective way possible. And as we do that, that will be an opportunity to see what the operations entail, what the costs are, to be able to better assess that. So we can't say that at this time. And I think this is an area that we would be happy to continue to discuss with you.
Yeah, that would be wonderful. Thank you, Madam Secretary. I think for our purposes, it would be really helpful to have, please, like a breakdown of what you all have envisioned at this time. Because you have a very specific number outlined for cost shift of $1.58 million. So it'll be helpful to understand how you all came to that number, what you're envisioning. Furthermore, I know that the locals are concerned about just kind of addressing sort of my high-level thoughts on this in general, but what we're hearing from locals, they're concerned about the added cost to their local jurisdictions. But I'm curious, I recall in the AOT discussion and debate, and it's possible it's also included in the DLS analysis, that part of the policy rationale for implementing a program like this is not just to, support individuals with very challenging behavioral health needs, but that this could have a positive benefit, like CCBHCs, on our emergency room backlogs and individuals who are going there for additional care, but on the local budget side, also on our detention facilities, right? Because a lot of these individuals that are seeking or that would benefit from AOT also happen to be individuals who have, are chronically cycling through our local jails and detention facilities. And so I'm wondering if in your conversations with the local jurisdictions, because you've been building this out collaboratively with them, they've spoken about what they anticipate seeing, or any population that they've identified as potential candidates that also overlap with those that are chronically cycling in and out of our detention centers.
Sure. I'm happy to take that, and thank you for the question. And I'd say that exactly the populations that you've highlighted, I would say in general in our discussions about AOT, including with our locals, I think are those that we most hope AOT will help. That this will be another tool in the behavioral health toolkit to particularly engage that individual who's struggling with non-adherence. I think our locals really have an excellent pulse on the ground in terms of those individuals. Many of our jurisdictions I work with can immediately bring to mind specific names of individuals who they know to be cycling and heavily utilizing services. And so I think exactly who you're speaking of, those individuals who might chronically cycle in and out of emergency departments, inpatient, also be at risk for arrest and incarceration, are exactly the individuals that we hope AOT will engage and ideally break that cycle for a subset of those individuals with serious and persistent mental illness.
Thank you. That's extremely helpful to highlight. And I know, you come to us by way of really incredible work that you've done in other states. And I know other states have also implemented AOT, and I'm wondering if, we could benefit from just taking a look at what savings that have been generated by local jurisdictions that now are having individuals not cycling in and out of detention facilities, right? Because this is not where they belong. An individual who has a chronic mental health need and is having difficulty adhering to a behavioral health plan should not be in our detention facilities, and yet we're seeing that, right? And I just want to take a moment to call out and thank Madam Speaker and former Judiciary Committee Chair Klippinger for an extensive amount of work that they worked on last year and are continuing to do now with Chair Bagnall on what are we doing to divert individuals away from jails who really do have mental health needs instead and could be better treated elsewhere. And AOT coming online is really going to be an incredibly important advancement for that specific subset of population. So thank you for your work. We really appreciate it. It's very good and important work. I don't see further questions from our colleagues, so well done on your first hearing before us.
Thank you.
Well done, MDH team. Thank you. As is the tradition, as my friends here from MDH know, and you might have heard, Madam Interim Secretary or Deputy Secretary, there's so many titles before your name. I apologize. Or not, I don't apologize. I don't want to trip over them. We have a tradition in our subcommittee of asking our departments to please stay, hear from advocates, and what their views are on the budget. And so we'll take them next, but thank you.
Thank you.
Thank you.
Of course.
Thank you.
So I will call, because we have 4 seats here, we'll call 4 at a time, and if I don't see any movement, we'll add some more people. So Ann Geddes, Mental Health Association of Maryland, Jason Woody, Baltimore Clubhouse, Shannon Hall, Community Behavioral Health Association of Maryland, and Adrienne Breedenstein with the Behavioral Health System of Baltimore. 1, 2, 3, 4. Great. Okay. And once you're settled, you may begin. Thank you.
Thank you, Madam Chair, Madam Vice Chair, and Subcommittee members. Again, I'm Ann Geddes with Mental Health Association of Maryland. First, I want to start out by thanking the Behavioral Health Administration for the great work they've done this past year with limited resources, including their planning efforts on CCBHCs, on assisted outpatient treatment. And I want to just note that we're especially grateful that they were able to sustain funding for the mobile response and stabilization services pilots that we have in the state. Those services are so critical for children, youth, and families. MHAMD supports full funding for the Behavioral Health Administration and requests a modest 3% funding increase for public behavioral health services and for all behavioral health grants in FY27. This is a necessity. The need for quality mental health and substance use care has never been greater. All indicators show that both children and adults are experiencing behavioral health concerns at record-breaking numbers, while the ability to access care is becoming increasingly difficult, with many providers leaving the field. The extent of the behavioral health workforce shortage in the public behavioral health system was well documented in a 2024 legislatively mandated report, and low pay is the #1 reason for this workforce crisis. Medicaid rates have not kept pace with salary increases for counselors outside of the public behavioral health system, and with growing inflation over the last several years and no funding increases, the shortfall has become even more acute. This is unsustainable. Like last year, Maryland once again facing a daunting budget shortfall. We recognize the challenge and understand that difficult decisions will have to be made, but we believe that a 3% funding increase for community behavioral health care is a sensible decision. Quality, accessible mental health care and substance use care is essential to the state and to the well-being of our children, families, and communities. We urge you to continue to invest in accessible and effective care. Thank you for your attention to these comments and for all your work to support behavioral health of Marylanders. Thank you.
Good afternoon. Thank you, Madam Chair, members of the subcommittee. I'm Shannon Hall, Executive Director of the Community Behavioral Health Association of Maryland, here on behalf of our 95 members delivering mental health and addiction treatment services to Maryland residents. In our system of government, it's your job to appropriate money and to direct how the executive branch is to spend it. 3 different times in the last 10 years, this body has unanimously told the Department of Health to pursue the CCBHC model. Unanimously, with full bipartisan support. I am here to ask you to send that message a 4th time. You can see more details in my written testimony. We have The majority of our CCBHC federal grants expire September 30th. We need a timely, good faith response by the department to sustain the model in Maryland. It's a model that covers the uninsured in the cost model, a need more acute with HR1, which will increase the uninsured, particularly among those with addiction needs in the coming years. I also ask you to ensure that this budget and BHA's funding is adequate to meet the needs of Maryland's behavioral health, the residents of Maryland. DLS cites 3 different variables in terms of determining whether the funding is adequate, looking at utilization, provider rates, and Medicaid enrollment. I want to put a 4th variable in the mix for you, the rate of need. It's growing in Maryland. Our youth, the rate of substance use among Maryland youth ranks us 31st in the country. The rate of depression among our youth ranks us a shocking 49th in the country. We need a system that meets need, and that's why last year's level funding left half our members operating in a deficit. Level funding this year will mean we're shrinking our capacity in the face of that need. We ask you to address the funding and increase provider rates 3%. Thank you.
You want me to go? Sure. Oh, okay. Good afternoon, and thank you so much for the opportunity to testify today. My name is Jason Woody. I'm the Executive Director of Be More Clubhouse. We serve adults experiencing serious and persistent mental illness in the Baltimore area, and we're Maryland's only accredited clubhouse program. Our model rests on a simple but critical belief that people living with mental illness don't just need clinical treatment, they need community, contribution, and purpose. At Be More Clubhouse, our members run the program alongside our staff. They pursue jobs, education, and safe and affordable housing. Research from Baltimore, as well as clubhouses globally, produce the same results: fewer hospitalizations, lower public costs, better employment outcomes, and significantly increased quality of life. Our organization is in support of BHA's budget for the upcoming fiscal year. We're grateful for the administration's continued commitment to community-based behavioral health programming. And I'll echo, as that commitment grows, we urge this body to ensure that reimbursement rates at minimum keep pace with inflation, because of course stagnant rates erode the ability of our community providers to maintain quality staffing and services. We also hope to see BHA follow through on including the clubhouse model in its upcoming rate study. A thoughtful, data-driven review of reimbursement for clubhouse services in Maryland is long overdue, and we believe it will affirm the value and cost-effectiveness of what we do, ultimately leading to an expansion of this model in Maryland. Finally, thank you to BHA, the members of this committee, and to the many providers and advocates here today. Inspired by everyone's commitment and look forward to working with you all. Thank you.
Good afternoon, members of the committee. I'm Adrienne Bridenstine. I'm the Vice President of Policy and Communications at Behavioral Health System Baltimore. Thank you for hearing my testimony today. For those who aren't familiar with us, Behavioral Health System Baltimore, or BHSB, is a nonprofit, and we are the local behavioral health authority in Baltimore City. We are MDH's local arm for managing and overseeing the public behavioral health system in Baltimore City. So I just want to emphasize my support, full support for full funding for the Behavioral Health Administration. One thing I want to highlight is that BHSB is in support of the phased-in approach for AOT. We appreciate the department bringing the partners and stakeholders together to reach consensus on this approach. We think it's really important because it's going to help answer a lot of the questions that you had today, in particular about how much is it going to actually cost to locally implement this program. Baltimore City is one of the 3 jurisdictions that will start the phase-in. It'll be important to gather that information, to know how many people we're going to serve, and then also figure out what's the budget, what's the cost going to be statewide. So we appreciate the ongoing work to implement that program and continue to be at the table for that. 2 other things I just want to emphasize that you've already heard from my colleagues. CCBHCs, we love them. We have a couple of them in Baltimore City, and we want to see more. As the conversation continues to focus on quality providers and elevating the quality across the system, I cannot emphasize enough how much CCBHCs is a model to do that. The integrated care model, the data reporting and the outcomes that are expected for CCBHCs, and the prospective payment model all contribute to them being a higher quality type of provider. So we just encourage the committee to continue to focus on that and appreciate your focus already on it. And then the last thing I'll say is around addressing need. We've continued to see the need for services for the public behavioral system increase in Baltimore City. We also would like to ask that you consider having a 3% reimbursement rate increase for services. We work with providers on a regular basis, and several of them have come to us, even recently, saying that they may need to scale back or close their doors. We don't want to see that happen, especially at a time when need is continuing to grow. Thank you, and I'm happy to take any questions.
Thank you so much to this wonderful panel. Delegate Ruff for a question.
Thank you, Madam Chair, and thank you all to the panel for your advocacy. Ms. Hall, if I could ask you, if Maryland, in your view and in your study of CCBHCs and the implementation of the federal program, if we were to apply for the demonstration, is it your understanding that state administrative costs like technology upgrades, staffing, infrastructure, data infrastructure, would be eligible for the enhanced federal match, or would all of those costs essentially fall on the state?
Thank you for the question, Delegate Ruff. It's our understanding that the technology upgrades required by the state to sustain the CCBHC model are matched by the federal government, that the federal government picks up an enhanced 90% match on that. The answer is a little bit more complicated on whether the model would pick up enhanced federal match for state staff, but the short answer is yes. It just might take a couple more steps to work there. But we see no reason to think there's anything unique in Maryland that would make our federal share lower than what we see in the other 7 states looked at in the DLS analysis.
Okay. Do you have any response to the question that I asked of our analyst, Ms. Kimura, and of the department about the difference between, have you even seen that exhibit?
I have, thank you.
Good. Do you have any kind of opinion on the disparity between the state match that we see in the 7 other states and what is projected for our state?
Thank you very much for the question. It's, I was grateful to have the question posed to BHA, but a little mystified by their answer, saying that they're saying that they think the federal tab will be lower in Maryland because the CCBHC won't cover the uninsured. Costs for the uninsured are literally built into the cost template for CCBHCs. It's one of the strengths of the model. So I'm not sure why the state is predicting that the federal share in Maryland would be 39% when it's 65 to 85 in all of the other states that DLS is looking at. There's nothing we are aware of that makes Maryland unique or different from these other 7 states.
So are you saying that Maryland is underestimating its ability to draw federal funds for these programs?
That's what it seems, and it would be, we would love to know more about what it is this year. Last year, I think it was a different rationale, and before that, it was a different one. So, I think with DLS, the analysis shows you the experience of 7 different states, and we're here to partner with BHA in making this a successful project that we can sustain for Maryland.
And I guess my last question would be, so it's your opinion that we could sustain the true price tag once we account for the state infrastructure required to support the demonstration?
Yes, I have categorically no reason to think there's anything unique or different about Maryland from the rest of the country in this respect.
Thank you. Thank you.
Sure. Thank you, Delegate. Thank you for the response. Seeing no further questions for this panel, we thank you very much for being here. And we will call the next 4 individuals. I have Katie Rouse from On Our Own of Maryland, Carrie Cho, Cornerstone, Montgomery, Stephanie Slowly Little, NAMI, Maryland, and Morgan Mills, Compass Government Affairs. 1, 2, 3, 4. Great. Okay, welcome. Nope, I see actually 3 people walking down. So I'm going to call the next person, Therese Hessler, Hessler Government Affairs.
Hi, may I start? Fantastic. Good afternoon, Madam Chair, Vice Chair, members of the committee, administrative leaders, community providers, and fellow advocates. I'm Katie Rouse with Honor of Maryland. Just thank you so much for the opportunity to speak today. And we represent a statewide network of more than 20 peer-operated wellness and recovery centers that are primarily funded through BHA grants, which is 3 decades of support and partnership and growth. We're very grateful for all the insights that have been offered by everyone speaking today, and I'd like to use my time to just speak a little bit about the peer workforce and the importance of community-based, peer-led recovery support. So last year, our network served over 10,000 Marylanders who are living with serious mental health or substance use needs, and that is an increase from about 7,000 the year before. Most of these centers run on an annual budget of about $200,000 each year from their BHA grant. But they have an average census of 20 people a day and serving maybe 250 unduplicated people each year. Some are much larger, serving hundreds of people over a region. And if we were going to do some comparative context calculations, that sort of works out to be about $66 per member per month for an unlimited number of visits with no wait lists, no assessments, no referrals, no insurance cards needed. Nowhere else in our system offers the same sort of truly accessible, affordable, everyday recovery support that's designed and delivered by and for people with lived experience. Although I will say CCBHCs have a similar sort of model when it comes to clinical services. Our network does a lot with a little, and we're so very grateful for all the past provider rate increases which boosted our budgets. But much like our clinical colleagues, we're still understaffed and we're overloaded with people seeking support, especially because of some of the changes in policy. Grant-funded community services like ours are essential, and we're cost-effective partners in the continuum of care, and our doors can stay open to all people in the face of shifting insurance eligibility criteria or coverage limits. Folks who might struggle to access traditional services from fear or stigma or financial barriers are always welcome in our network. We de-escalate crises, we divert hospitalizations, we fill gaps with flexibility, innovation, and we achieve great returns on investment. But most importantly, we help Marylanders reclaim their lives, find hope and meaning and purpose, and connect with the treatment, housing, education, and employment that makes for a quality life. But we need your support to help keep up with the rising costs of just keeping the lights on, and importantly, retaining staff who deserve to be paid a living wage for their heart, their hope, and their hard work. So we respectfully ask and echo the asks for full funding of the BHA budget and the modest 3% increase that's going to help us to not fall farther behind the economic curve. Thank you so much for your listening and for your support.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. For the record, my name is Teresa Hessler, Ashler Government Relations, and I'm here today on behalf of the Recovery Housing and Treatment Center Coalition of Maryland. We represent providers from across Maryland who offer varieties of different levels of care across the continuum, and we appreciate the state's continued investment in behavioral health, particularly in a constrained fiscal environment. However, stabilizing the provider network must remain a priority to ensure access to care. From a provider perspective, reimbursement stability and reliable claims processing are foundational. The ASO transition has created uncertainty in payment timelines and categorization. I've seen this delay in payment firsthand, as this has been an ongoing issue with many of our members, despite ongoing conversations with Carolion. Continued legislative oversight and transparency around claims timelines and payment accuracy are essential. Additionally, we appreciate DLS including the ask for BHA to comment on whether or not it has designated staff working with local BHAs to investigate complaint findings and take appropriate action. We are very supportive of consistency and compliance between local departments and the state. As it pertains to COMAR updates and regulations, Maryland is far behind the national standard. While we appreciate the department's work in drafting updated regs last summer and the informal regs that have been introduced currently, they are still inconsistent with what the American Society of Addiction Medicine, or ASAM, recommends as best practices in their criteria. When proposed again, we would like to see these formal regs match the latest version of ASAM 4. To touch briefly on this, that criteria has 3 core components. 1, as a patient enters addiction treatment, level of care is assessed to identify patients' clinical needs. 2, it defines standards for different levels of care across the continuum, staffing, settings, service intensity, and other core elements. And 3, It reassesses continually as a patient needs change. In closing, we respectfully recommend ensuring accountability in the ASO transition, maintaining reimbursement stability, increased rates for providers, improving coordination across systems, and updating our state regulations to match ACM4. Thank you so much for your consideration.
Good afternoon, Chair Shetty, Vice Chair Jones, and committee members. I am Carrie Guthrie, CEO of Cornerstone. One of the original CCBHCs in Maryland, we provide behavioral health services in Calvert, Charles, St. Mary, and Montgomery counties. The governor's budget keeps Medicaid rates flat for behavioral health, while MCOs and hospitals get increases for a total of $453 million. It is community treatment that keeps people out of the hospitals. We are already expecting losses from HR1 and recertifications that will result in insurance churn and clients losing their Medicaid. That means that providers will not get paid. We are struggling already with poor cash flow and a lack of fiscal resources. Many of our programs have not fully recovered from COVID. Our clinic lost over 400 clients because many did not want to switch to telehealth. Supported employment lost at least 30% of their clients during COVID while people weren't working. We have not given raises to all of our staff in 3 years. Salaries are insufficient. We lose staff to government, schools, and hospitals. Turnover rates were as high as 40% during COVID, and licensed positions in our clinics take 3 to 6 months to hire. Intake for new clients has had to be closed in multiple programs because we don't have the staff to serve them. And without those staff, we have had to shrink program capacity, ACT by 100 clients, residential crisis by 8 beds, and behavioral health homes by 250 clients. We urgently request a 3% rate increase for Medicaid rates. For behavioral health, that is less than $50 million, or about 10% of the $500 million that MCOs and hospitals are getting. Community behavioral health providers keep people out of the hospitals and save millions in Medicaid. Please help us maintain these services to our most vulnerable residents and include a 3% rate increase in the budget. Thank you.
Good afternoon, Chair Shetty, Vice Chair Jones, and the distinguished members of the Health and Social Services Subcommittee. My name is Stephanie Soley Little, and I have the pleasure of serving as the new Executive Director for NAMI Maryland. And I represent 11 affiliates and over 60,000 families, persons living with, and advocates who are living with mental illness. And our organization provides free, accessible trainings, education, and supports to those families that are there. With the ever-growing changes that are happening federally, the fiscal budget that we're facing statewide, NAMI Maryland serves as the then what organization. And with the proposed cuts and not fully supporting BHA, we stand to lose critical supports that affect the people that I have to serve every single day. The two things I would like to highlight for the committee's consideration is, NAMI Maryland has been a staunch supporter of AOT, and for many years we served along with our colleagues championing this. We are very concerned about the potential of cost sharing shifting to the local counties. As a former local county employee, I was there on the front lines when there were hard decisions made when crisis was implemented and there wasn't a clear cost share. I was there when they were asked to do AOT implementation and they couldn't do effective cost sharing because they didn't have the resources. We want to ensure that we have equitable, patient-centered implementation of this program, but that takes all of us, financially and programmatically. I also would like us to lift up the proposed language around CCBHCs. And I stand with the colleagues that have already spoken around the need for expansion and restoration. Again, it's about the people who need the service. The communities that we serve cannot afford to go to several services that are not always equitable in each community, not always accessible, and not always open for them. It is critical that we look at that. The last is a 3% rate increase. While we don't think that that is sufficient for some, we understand that equitable funding of our providers equals quality care. When we do not reimburse our providers the fees and the rates that they are, we lose people, and we also lose access, and we also lose treatment. And for the people that I have the pleasure and the honor to represent, that's just too far. I urge you to consider and work to support BHA's full funding, find plausible and equitable solutions to treat the people that need it, and let us all work together to ensure that no Marylander truly is left behind and that behavioral health and mental health especially stays on the forefront of all of our minds, because we all need it. Thank you for your time.
Thank you, advocates. Really appreciate your work. Thank you. We only have one witness remaining, Brandon Shabazz Holt of On Your Own of Frederick County. Are they here? Great. Welcome. You can come on down, share your testimony with us. We'll go from there. Thank you.
Good afternoon, Madam Chair, Committee. My name is Shabazz Holt. I represent On Our Own of Frederick County, a peer-run wellness and recovery center funded in part through behavioral health contracts. Each month we record more than 1,000 check-ins with 200 unduplicated individuals. Half self-identify as unhoused. This year alone, we've connected an average of 2 people per week to inpatient treatment, doubling our original goal. I am here in strong support of continued and increased funding for community-based mental health and substance use services. My life changed because these services existed. I once relied on the very funding we are discussing today. Because of that investment, I have transitioned from participant to provider. I'm now a certified peer recovery specialist and training manager. In the past 2 years, I have trained and mentored more than 100 Marylanders with lived experience to join this very workforce. Community-based providers like ours serve individuals who are unhoused, living with mental health challenges, navigating substance use disorders, or returning home from incarceration seeking a real chance. We meet immediate needs like food, clothing, stabilization, while building pathways towards self-sufficiency. Our work also strengthens public systems, reducing unnecessary arrests, emergency room visits, strain on EMS and our courts. When behavioral health is properly funded, communities are safer and systems work better. We respectfully ask for a 3% provider rate adjustment to retain staff and to sustain life-saving services. Investing in community behavioral health is both fiscally responsible and deeply human. Maryland's most vulnerable residents are counting on it. Thank you for your time and favorable consideration.
Thank you, sir, for your testimony. Thank you for your important work in the community. Any members have questions? Thank you.
Thank you so much.
Thank you. That concludes the advocate testimony and the testimony for this hearing, and that concludes our hearing this afternoon. We will see you in our next one. Thank you.